Hi, my name is Ryan J. Allen. I'm partnered with Christian Smith. We're pharmacy students at the William Carey University School of Pharmacy. Today we'll be discussing the article, Public Health Outcomes May Differ After Switching from Brand Name to Generic Angiotensin II Receptor Blockers. Now, a little bit of background on the study. So we found that the substitution of brand name to generic drugs has shown both positive and negative outcomes. And because of these positive and negative outcomes, it is difficult to determine the clinical impact of switching between brand and generic drugs. This uncertainty is especially expanded when we have to balance those risks and benefits in cardiology patients. So we try to look at benefits of changing from brand to generic drugs, and we find that the biggest benefit is going to be direct cost savings for both healthcare systems and for payers. Now, although ARB generic drugs are not always identical in strength of active ingredient, galenic form, route of administration, or even sometimes indication, we find that the bioavailability of generic drugs compared to the brand name drugs is actually very similar. So as generic and brand name ARB drugs are considered bioequivalent, this retrospective cohort study was conducted to characterize the impact that generic substitution for brand drugs would decrease things such as emergency room consultations, hospitalizations, or even death in the elderly cardiology population. Now, some significant results from previous trials. Previous studies found that generic substitution was just as effective as brand name, as showed by several studies. And furthermore, a more recent study involving a generic sartan drug that affected millions of patients worldwide also benefited generics over brand as well. Now, the equivalence and safety of brand name to generic drug substitution may actually be a public health issue, and we can further discuss that in just a little bit. Now, why was this study conducted? So the authors aim to characterize the impact that generic substitution on the occurrence of emergency room visits, hospitalizations, or all-cause mortality in the elderly population would have. So as generic and brand name drugs are considered bioequivalent, the authors hypothesized that they would not find any difference in time to event between patients who continue taking the brand name drug compared to those who were exposed to generic substitution. So this study will help us determine how equivalent generic drugs used to treat hypertension and cardiac related disease states and how effective they are to brand name drugs. So the title of the study is Public Health Outcomes May Differ After Switching from Brand Name to Generic Angiotensin II Receptor Blockers. It was written by Jay LeClaire and her associates, who are all employees of the Government of Canada, as well as the University of Quebec. Now, no funding was received for the study. The study was a part of a continuous chronic disease surveillance mandated in Quebec, Canada. So all surveillance health activities of this mandate were approved by the Provincial Ethic Committee of Public Health. No informed consent was required. So the study was conducted in Quebec, Canada, and at the Institut National de Santé Publique de Quebec. So forgive me for my mispronunciation. I will work on my French as quickly as possible. So the trial design was a population-based observational retrospective cohort study. And the primary outcome was that for the hypothesis was that they would not find any difference in time to event between patients who continued taking brand name drugs versus patients who became exposed to generic substitution. So the primary outcome was that patients would not see a difference in generic substitution. So going over the methods of the trial. Now, the patients who were included, patients had to be over 66 years old. We're talking about elderly population. Of course, they have to be using an angiotensin receptor blocker for over 30 days. And it had to be a brand name ARB. It couldn't just be a generic because we're talking about generic substitution. And that's just before entry. So have to be on the same dose of that ARB for greater than or equal to 15 days before they start that study. Now, the patients who were included in the trial were included because they all have significant risk for an atherosclerotic event, and they all fall within the requirements to take ARB maintenance medication. Now, patients who were excluded, of course, are younger patients, so they had to meet the inclusion criteria strictly to be included in the trial. Now, although during the trial, the use of various generic ARBs were used, the trial excluded the use of patients who used pseudogenerics. So we included the exclusion of pseudogenerics in our exclusion criteria because patients would have to switch, and that could have skewed the results. So patients who were on pseudogenerics were not able to use generic substitution or be allowed in the study. Now, the intervention and the experimental design, the study investigators branched about 58,868 patients into 4 different arms. So you have 3 arms who did generic substitution with either a generic losartan, valsartan, or candesartan, and a 4th arm was used as a control group and was composed of patients who only stuck to their brand name ARB. Now, patients either switched from a brand name to a generic drug and fell into one of the 3 generic arms, or stayed on their brand name drug and fell into the 4th control group brand name arm. Now, patients who did not switch, sorry, I already said that. Patients who did not switch their drug from brand to generic stayed in the 4th arm. I'm sorry, I did not mean to repeat that. The cohort entry was attributed by time distribution matching, and all dosages of all 3 ARBs that were indicated to treat hypertension, heart failure, and losartan in 2010 and 2011 were used, and they were identified by their respective drug identification number as well. So all the medication were dosed appropriately, and the trial was just able to run its course. So for the outcome measures, in separate models, the study primarily analyzed the times from cohort study to predefined outcomes up to 1 year of follow-up. So they did the study and then did a year of follow-up. So results were recorded by each number of ER consultation visits, hospitalizations, or death of all cause. Secondly, the study evaluated the equivalence between brand and generic drugs used to treat hypertension and cardiac-related events. So continuing on with statistical analysis, and then move myself over here. Hello. The significance level was set at a p-value of less than 0.05. Descriptive analysis were performed on the available covariables traditionally studied in public health surveillance and known as potential co-founders in pharmacoepidemiology, including age at cohort entry, sex comorbidities within 1 year of cohort entry, and concomitant drugs within 1 year of cohort entry, a geographical proxy of socioeconomic status, duration of the brand name drug utilization before generic substitution, ER consultations, or hospitalizations within 60 days prior to cohort entry, region of residence, and the prescriber's specialty at cohort entry, as well as outcomes for each cohort to obtain proportions, means, standard deviations, or median and interquartile ranges where appropriate. Wow, what a mouthful. And they also used chi-square tests, independent t-tests, and Wilcoxon rank sum tests were performed to assess the univariate statistical significance between groups. And you might be wondering, well, why did they use so many different tests? It was just like, it kind of goes back to the funding of our study. Remember, this is a free trial, so we're just gonna have to roll with the fact that the testing that was done for some of these statistical analysis were at the discretion of whoever they had for free to do the test. So it was just up to the discretion of the statistical analyzers to choose whether they wanted to use an independent t-test, chi-square test, or a Wilcoxon rank sum test, as far as however they wanted to evaluate the data. Also used multivariable models to adjust for potential confounders that we previously listed. Also an explanatory 60-day endpoint compared to the risks of outcomes up to 60 days after generic substitution by multivariable logistic regression models. We also have a 95% confidence interval that generic drugs would be equivalent to brand name as far as reducing cardiac events. So I will leave the results to Christian. I'll pass the baton to him right now. Thank you.
Then for the results, we have a total of 58,868 participants. And for the baseline characteristics, the treatment and the control groups were similar at the beginning of the study. The accrued proportion of ER consultations up to 1 year was higher for those exposed to the generic valsartan and candesartan substitution. The accrued proportion of hospitalizations up to 1 year was higher for those exposed to the generic valsartan substitution only. And then the accrued proportion of death up to 1 year was 0.1% lower for those exposed to generic candesartan and valsartan substitution. The author states that it was found that generic valsartan caused an increased risk of hospitalizations, and generic candesartan showed a decreased risk of death when compared to the brand name drugs. We thought that the author's conclusions, they were parallel with the study results. So I think he had the right state of mind when he was talking about this. And also, I do think the author was open to any potential bias and limitations. It seemed like they weren't trying to hide anything. They were pretty upfront. The only thing I think there needed to be a little bit more hard evidence, and possibly a larger participant group would make the results a little better for me. The strength and the weakness of this trial were both the same, and that's the complexity, because we thought that the specifics of the trial, they were presented in a good way so you could get an in-depth critique of it, but also the complexity made it a little difficult to read and comprehend. So we agree with the author's conclusions and believe that the trial was worth the risk and costs. We think it was something that was good for these patients, that it was something that they actually wanted. These patients are like many other adults because they take medication, and it's generic and brand name. So we think that the study addressed the issue that these patients, cared about and could relate to and deal with on a daily basis. We don't think that there was enough hard evidence compiled to make us want to change any opinions based on the results that were found. Then we have our references here. And then we have a chart that kind of summarizes it a little bit down there.